table here is lots of information. There's a few new people in here, and so I want to make sure you're aware. We have our membership applications, which will be due in January for next year. And also, these are awesome little cards that Lance with River Glen had printed on our behalf. So if you want to take a few of those, if you're educating anybody about what the Senior Care Alliance does, please feel free to do that. Also, we have a sign up for the general meeting. So if you, as a company, sponsor a general meeting, which would include, the food like Brittany's doing today, then your membership fee is waived. So I want to make sure you guys all know that. Excuse me. Next meeting is our last meeting of the year. I can't believe it's already December. And it's going to be hosted at Hope's Creek on December 17th. And our last coffee talk of the year is December 9th, and it's going to be at Van Buren Senior Center. I want to encourage all of you guys to check out our website. I know Louise gets a lot of calls about what's going on in our events. Our website's always up to date on what's going on with the Senior Care Alliance. Next month in December, we'll introduce the new board to all of you guys. We have 5 new board members, and they'll be going kind of through a little bit of a orientation process between now and then. And think about committees. In our board meeting, one of the things we talked about was most of the things that we do, like planning of the conference, which is a huge event, or coffee talks, we have committees that work on those. But most of our committee members are board members, and so we've had people say, I would like to serve on that committee, and so I want to make you feel welcome. If you want to help us with the conference, we would love to have you on the committee. So just because you're not a board member doesn't mean you can serve on any of the Senior Care Alliance committees. So those are the main things I wanted to talk about. Any other announcements? Did I miss anything? Okay, and then I'm going to introduce. Most of you probably know Brittany. She is a Senior Care Alliance board member. She's an advocate for residents and patients. She's an awesome marketer and educator for our community. And so, Brittany, I'm going to let you take it over.
All right. Thank you, Holly. All right, guys. So I wanted to talk to you about different levels that all hospices have to provide. This is Medicare guidelines. So we can kind of talk through each one. I know several have worked very closely with hospice. They've had personal experience with hospice. So I wanted to see if there's anyone in the room that may not have had as much experience or just not quite as familiar. Can you raise your hands? Okay, so this is a refresher class. So please, I love engagement. Ask questions, or if you have comments, let me know. I have Dr. Anderson with us today. He's here to critique me and help with any questions that you guys might have that I don't know the answer to. So feel free to interject whenever you want as well.
Okay, thank you.
All right, so these are the 4 levels that all hospices have to provide, okay? We got routine, general inpatient. A lot of people will say VIP, and we're all bad about using acronyms, so I want you guys to kind of know some of that slogan too. Continuous care and respite. Routine care is going to be provided wherever that person calls home. Private residence, a nursing facility, assisted living, Hope's campus. We've even taken care of people that were living in a tent. We are going to go where that patient is to provide the care that they need, regardless of the social situation. I do want you guys to kind of understand that, because a lot of people are, they don't get a lot of resources they need when certain situations like that happen. This is going to be a care plan that is based off of their needs and their wants. So it's a flexible care plan. We're going to typically see nurse visits weekly, home health aid, most people want 5 days a week, social worker chaplains more on a monthly basis, volunteers get into play as well. But let's say they don't want a home health in there because they have, or home health aid, because they have a non-skilled caregiver in the home and they're more comfortable with that person. They're not going to get a slap on the hand for refusing that service. They really just need that nurse visit weekly and the physician oversight to meet their Medicare guidelines. As someone starts to decline and their needs are increased, then our nurses are going to have a goal to see that person daily. I still want you guys to understand it's supportive care. We're available 24/7, but those disciplines that are going out there are there for about an hour. We can go out day or night, holiday, whenever it is, but whenever those visits are there, it's not going to be a continuous day for them. So a lot of the care is still going to be put on the family or caregivers that are there with the patient. With this includes medication, supplies, equipment. I think all of you guys are aware of that. My goal here is to really talk to you about what general inpatient criteria is, so if you have any questions about routine care, we can circle back to that. So, most of you probably all know we do have a hospice unit at Baptist. We rent out that location. We have 11 beds there. We have a physician that oversights that. Her name is Dr. Schroyer. And we are looking at people who are hospice eligible that is in a symptom crisis. Sometimes it gets a little confusing. Has anybody had any experience with trying to get somebody to the unit before? Yeah. So a lot of times we'll have people who are transitioning. We do feel like their prognosis is very shortened, and if they're in the acute care setting, our thought is let's move them up to the unit and let them be with their family, right? Sometimes if they are peaceful, lying there comfortably, that is not a guarantee that they can go up to the unit for end-of-life care. We have to see that there are symptoms that are not being managed. The main one is pain. We all, can identify that pretty fast, but also think of nausea and vomiting that is uncontrolled. Advanced wounds is always going to be there. It shows up on the Medicare guidelines, but I haven't seen that myself. But we're going to be looking at wounds that are taking multiple nursing staff to go in there to address. Orders are having to be changed frequently. They probably need a lot of pain management for them to be able to do those wounds, like kind of out of the ordinary type of wound situation there. Respiratory distress is one that we can also look at for IPU. And then also suicidal ideation or like terminal delirium or terminal agitation. If you guys are, active with clients or in facilities and you see patients that you cannot console them, if you try to give them medications, they might be spitting it out or swinging at you, whatever it may be. If they're hospice eligible and, we've kind of ruled out any acute things going on, it could be that terminal delirium or that terminal agitation is a factor, and we may need to look at assessing them in the unit for IV medications. So all of these are some of the symptoms that we're looking at, most of all the symptoms, but we need to kind of condense it down to like how frequently are we having to do an intervention to help them? Is it hourly that we're having to change something up? Is it more frequent than that? We've seen situations where it's every 15 minutes, like we're not getting what needs to be done, taken care of. Those are the type of patients that would qualify for this level of care. If we go in to assess somebody, and this can be in the hospital setting or assisted living or even in the home setting. We've had people on home hospice get into a symptom crisis and go directly up to our unit for care, okay? So we walk into the room and we see they are just very uncomfortable. We've tried the medications, we've changed orders, that's not working. What's our next step? And that's when we call our physician, see if we have enough to support IPU eligibility, and move them to the hospice unit for that care. The average length of stay is typically about 3 days or so. Our goal is to get those symptoms under control and on a regimen that can be done at a lower level of care, okay? Sometimes we do have people that does end-of-life care with us. We often have people that do stabilize, and we have to look at a discharge plan. This is important for you guys to know in case we're doing an evaluation on somebody for the unit right out the get-go, and we feel like, they have a lot of reserve, like maybe their sickness has came on pretty fast. They're pretty critical that we might be able to get them in the unit, but we think we can stabilize. We're going to have to start talking about discharge plan pretty early on. That can be hard for families to kind of start talking about those things when we feel like this is probably going to be our last stop. So I just want you guys to know we're having those ongoing conversations with them. Our hospice unit said we have the physician, we have RNs there around the clock, we have a social worker and a they have the whole care team just like the routine care does as well. I have on here just a few resources of where this criteria comes from, like the Medicare guidelines. It can be kind of vague, but it all comes down to the frequency of the medication. We do some pretty unique things in the home setting too. I'd like to share with you, and Dr. Anderson, you can jump in if you want to, but a lot of people feel like, hello.
Hey, how are you?
Hey.
Sorry I'm late.
No problem. I've actually had a patient that was at the hospital who was on a Dilaudid pain pump, right? And so he's getting one of the best medications. He's getting it pretty frequently. The family did not want to go to the unit. They wanted to take him home, and his family cared for him. We were able to get him set up with a Macy cath in the home setting. Has anybody ever heard of that? Okay. So I'm sorry if you have a weak stomach, but
You said Macy
a
cat?
Macy cath, yes. So it's a small Foley-like catheter that is like the size of your cell phone charger, very thin, and it goes in rectally, and they can administer medication, flush it after. It works very fast. You've had some experience with it. Well, it worked wonders for him. He had his pain under control. He could be at home with his family. You can administer that pretty frequently too if needed. Those are some of the other things that we can do at home to honor these patients' wishes. Another story I like to share that is kind of outside of what you would typically see was a home patient that had been on hospice. She had a bowel obstruction. She had nausea and vomiting. She wasn't passing anything anymore. So you can imagine what was happening. She was miserable, right? If you gave her anything orally, it wasn't going to take because she was vomiting everything she had in her mouth. We put her in the unit. They dropped an NG tube. They were able to monitor her symptoms, give her IV medications. She had dignity. That's what this is for. So she was able to spend her last few days with her family and not be hovered over a toilet. So I can always print these out for you guys if you want some just more clarity about it all. But it's not too hard once you break it down and look at it as, okay, do we have a symptom crisis on our hands? This is what we need to treat. This is the kind of level of care that we're looking for. These are some of the resources if you need that. Okay, continuous care. I don't think we do this very often, if at all. I think maybe the POTO part of hospice did it for my family because we were really needy at one point, but this is for the people that are in a symptom crisis, but there's a lot of family in the home and they want to try to stay there. So we have staff coming around the clock. You would think, okay, maybe this is the 24-hour hospice care. It might get very close to that, but the regulations say that 51% must be provided by an RN in 8 hours of care within that 24-hour period. So we can also utilize our social workers to help supplement some of those hours as well. So a lot of foot traffic coming in to help manage those symptoms. For folks that have the Macy cath at home, that might be something that they need more, help with and more education. Our goal too for hospice, one of the biggest things that our nursing staff has to do is the education. We're teaching these families how to care. We're teaching them and reiterating that they're making the right decisions and we have their best interests at heart. So it is our job to kind of guide them through this because we are the support care for them. And I don't think we see that very often, continuous care, because we do have the unit, and most people are more comfortable with them going up there. Now, you guys might ask, what if there's not a unit? I think we can all know that census has been low with some moving cares and whatnot, and all hospices still have to carry that level of care if they need it. So we all have contracts with different places to be able to provide general inpatient care. So we actually have a contract with Baptist Hospital. Sometimes we'll have our hospice patients go to the hospital out of fear, whatever it may be, and we don't automatically discharge. We actually have to pay Baptist a portion for our hospice patient being there and pay them for giving care to our patient. Our nurses visit daily and help with that discharge plan, But that's the type of setting that's going to be for any hospices that do not have a hospice unit. They're gonna have contracts with hospitals so that they can provide that level of care. It's just gonna be a team approach. Does that make sense?
So what does Mercy do now that they no longer have the inpatient unit?
Primarily the rural hospitals where they are doing their GIP. And I know they're doing some comfort care in the main hospital too.
So they just do it on the regular floor, do you think?
I know when they transition to comfort care in the hospital, they're not electing the hospice benefit because we will get a consult on those folks that are on comfort care, and we don't have to do a transition, a transfer to our hospice whenever we take them in. So they're doing like a comfort program, not electing the benefit. But I do believe in the rural hospitals, they are, they're providing that general inpatient care in the rural hospitals.
Just in the regular floor?
Yes, yes.
I'm actually not sure. Mercy.
Yeah. Do you want to add on to that a little bit?
Nope, you hit it. No, yeah, we do. We have, on V500, we have the 2 suites.
Yes.
That they have elected for the comfort care.
Yes.
And our hospice team, whenever we get a palliative consult, our hospice team will go with the palliative APN to visit with that family during the family consult.
Okay. And that's when they're on comfort care, not electing hospice.
Yeah, and at that time, whether they decide whether they continue with palliative or they flip over to the hospice and work on a discharge plan.
Gotcha. And I think primarily, correct me if I'm wrong, when you see people go to GIP in like the rural hospitals, those are current patients that are maybe needing that level of care at that point.
Probably so.
Yeah. We do have contracts with, nursing homes and whatnot, but the guidelines is that for GIP level of care, an RN has to be on staff around the clock. So you're primarily going to see like general inpatient care done in the acute care settings for that reason. But you know what we can do in the facility is respite care. So just in case, I know like non-skilled providers provide respite care too. I think that can be a blanket term and be a little bit confusing for the community, but hospice does have to provide this level of care as well. And ours consists of 5 days in our hospice unit or in a nursing home that we have a contract with for 5 days. So the caregiver can get what they need done. This is very important for these caregivers. I've heard time and time through speeches that our caregivers may have a shorter prognosis if they don't take care of themselves, right? I think what just makes it a little bit unique is that we are able to truly have them go somewhere for around-the-clock care. And that caregiver, if they decide to come up to the unit and stay with them, they can. A lot of them do, but they can truly stay home and get healed up or take care of what they need to do. There's no maximum amount of times that they can utilize this. We just cannot see, it can't be a pattern. We can't be like, oh gosh, top of the month, it's time to take them to respite. We have to have valid reason why they need this level of care. Something we see quite often is that maybe we have someone living home alone. Maybe they do have a agency coming in to help with some caregiver help, but maybe just a few hours. They don't truly have a caregiver that we can utilize the respite benefit for. They have to have somebody to be able to utilize this. We also can't go from the hospital directly straight into respite care because that caregiver doesn't technically have that caregiver fatigue because their loved one has been admitted into the hospital for X amount of times. So, any questions about any of that? I think that ends my little short tidbit of information. So, anything I missed?
No, you did great.
Okay.
Do you know the surrounding outlying areas, hospitals that do have a hospice, have a contract with hospice, or like if you have a patient in, let's just say Poto, I mean, do they come here to Baptist, or do you have like do you have rooms at Poto?
Contracts out there. So we do have our Poto agency utilizes our unit for their respite and GIP needs. They do have contracts with the nursing homes in that area. I don't think they have a contract with like Sequoia East or the Poto Hospital either. They primarily will just use our unit for that.
Okay, and for GIP, do you have to be licensed as a hospital or can it be within a nursing home?
So they do have to be licensed beds. I just heard word of that because I actually wanted to kind of dive into this hospice house and see if there was an opportunity to have a bed there for GIP. And because it's not licensed, we wouldn't be able to do that. So if your facility had an RN around the clock 24/7, then we would be able to do a GIP bed there. And that nurse, that RN doesn't have to be the one assigned to the patient. She has to be in the building. So we've had situations where we have an RN on call. They do need to be in the building. Any other questions?
So what qualifies somebody for hospice, and then what also gets them, like I've had a couple clients that have been referred to, but they graduated off of hospice. So what causes somebody to get onto it, and then what also causes them to graduate from hospice?
That does happen sometimes. So Medicare lays out guidelines for different diagnoses. So it can be a little confusing. It is our job to kind of identify what diagnosis we're going to be able to admit them for. And at times, we even change the diagnosis after they've been on services for a bit. So a good just like trigger for hospice is in the last 3 months, have they had a significant decline and they're not bouncing back? Infections, weight loss, they're not eating as much, they're not verbal anymore, they're dependent on most of their ADLs, those kind of things. Of course, different diagnoses will look a little bit different, but that is the general consensus. So the times that we have people graduate out of hospice can look a little different too. There are times that we have people come on services because they have been so limited in resources that they can get that they've become non-compliant. They can't afford their meds, they can't get home health out there, they've just given up on life, and they become hospice eligible. We get their medications paid for, we get a team approach out there, we help them get on a better track, and they have improved, either stabilized, remained on hospice, or graduated. A lot of times we'll get very sick, chronic patients on hospice services that are bed-bound, peg feedings. They maybe have supplemental oxygen and they have caregivers in there every 2 hours turning them. That kind of person can live a very long time, right? So they can be on hospice for a long time as long as they meet those guidelines. It seems like often when we have those folks, they get like bronchitis. Well, that's an infection that has helped support us get another certification. But if they're not, and they're not having any more weight loss because again, we're feeding them regularly, we're giving them the oxygen, we're taking care of their skin, they may have to graduate. And that's really difficult because then it's really hard to get any home health or anybody like that to be able to pick them up because they're so low level. Unfortunately, those folks kind of are in a bad spot to get services. Does that kind of help?
Yeah.
You're kind of supposed to be able to say medically that you believe that they're gonna live 6 months. I mean, that's the Medicare thing, is you expect them to live 6 months, and so then many times that's not correct. I mean, we have a hard time really pinpointing that type of thing, but if they live much longer than that, then we have to kind of start looking at it and saying, well, are they declining? If they're not really declining, then you do kind of get into this, well, we might need to discharge this patient because Medicare starts to kind of audit those things.
Okay.
And then if they decline after that, then can you pick them back up?
Yeah, and that's frequently what we try to do is put one of our palliative people in there as we leave, and then they can kind of keep an eye on things. Or many times they're in a nursing home and the nurses already know them, and they'll kind of see them, you know, kind of keep an eye on things as they go back to visit other patients in that nursing home. So we try to keep an eye on them, and you know, frequently they will come back. They'll be out for 3 or 4 months, and then they'll come back to our services.
And they don't get any they're not penalized for coming back on or anything like that. So it's not an issue for them. Any other questions?
It does become a little bit of a thing where people want to continue to do aggressive treatments, and so they'll go back to the hospital to do something, and then we're kind of like, well, should we discharge? They're doing this, they're continuing an aggressive treatment, want to go get surgery or do various things, and then they'll go back to the hospital, they'll do whatever it is that they're planning to do, and then they'll want to come back to hospice. And many times the reason they want to come back is because they're so good. We have nurses, we have social workers, we have the pastor that comes to your home, and all these services that people appreciate and enjoy, and so they don't want to be discharged from hospice many times, but they're not quite hospice minded many times. They're not quite ready, and so.
So when you say like give up on life, what does that look like?
So, when I mentioned that, I was talking like they are just not getting the resources that everyone's telling them they need, like rehabs. They can't afford their medication. They just kind of give up, right? Because what are they going to do? They are having a hard time getting to their appointments because of financial barriers, whatever it may be. So we can't technically use failure to thrive as a hospice diagnosis anymore, but there is lab work that supports that will help other diagnoses, different comorbidities. So I guess if for your clients, if you are starting to notice they're withdrawing, they're not wanting to be a part of, conversation much anymore, maybe they don't want to get out and do things anymore. And,
So it's one of those, like, she's a fairly new one, but you had a caregiver go out there, and when we got the referral, it was actually from APS, so Adult Protective Services has already called us out there and says, hey, she's pretty much like showing pretty much a failure to thrive. So we go out there, my caregiver documents like literally a book, and it's like she's MS, doesn't want to move, doesn't want to get up. She pretty much hasn't moved in the same spot for like 2 months.
oh my goodness.
So it's like, what do you do with that? And then, so I'm just thinking to myself, like, what other resources can we do? Because if we're just there for an hour, and she doesn't even want us there, she's combative. She can't stand on her own, but then again, she's not trying to stand on her own anyways. And, it's making it hard for, each, depending on what caregiver I put out there. So I put one out there that I know is gonna be like, come on, we're gonna just get this done, and at least until Adult Protective Services says, all right, enough is enough. But I know they can't, I don't think they can afford it anyway, so it's like.
And she might still cognitively be in the right mindset where they're limited on what APS can do.
Right.
So in those situations, I just recommend asking Miss Smith, would you mind if I have somebody with more resources that you may be eligible for come talk to you? I know somebody with palliative and hospice care that maybe they can come to you to provide care if you're agreeable to talk to them. And then you just call us and we'll send a nurse out there. And what that looks like is once they get there and they look at the medical records and their assessment, they call Dr. Anderson if he's on that team and say, hey, this is what I have, this is what I'm looking at. Do you think we have enough to support eligibility? He says yay or nay, and from there we can start care if she's agreeable and eligible. And it's no money out of her pocket, her insurance carries it all.
Okay.
I think that would be a good start. There's no obligation to if she decides, I don't want that.
Yeah, she really wants us
I'll
there.
start acting right.
Yeah, right.
Sometimes that might, get them an eye opener, like, okay, I'm gonna need to start doing something for myself. MS is a very long diagnosis.
Right.
And there's certain criteria for that diagnosis, but with some of the other things that you shared with, her not eating and whatnot, that's where we can take in some of those other comorbidities to see if we can support it.
Okay.
Anybody else have any comments or anything you want to share?
Yes. When it comes to insurance, like, is there any insurances that don't cover?
Right now, we are golden. So, think about like your managed care patients, we're really, it's difficult to get them help. When they elect the hospice benefit, they revert back to Medicare. So we don't have any issues getting any of those folks taken care of. If they're Medicaid, there's a hospice benefit. If they're private insurance, there's a hospice benefit. If they don't have a social security number, I'm fortunate I work for a company that's big enough that can take in indigent patients and give them the care that they also need. There are, like Oklahoma, our agency there is a little bit smaller, so they do have to look at the numbers. I have not yet had them turn away a indigent patient, but Oklahoma Medicaid does not have a hospice benefit for whatever reason. So those are also considered indigent for those people too. So what I like to say is all hospices are like this. If you get a no from one, but based off of their numbers, call the next one, and they should be able to get you taken care of.
I've been turned down.
Yeah.
And I call a lot.
Yes.
So when you say it goes back to the traditional Medicare, is that like right away, or is it like if you do a new Part D plan and you have to wait until the first of the month for that to take over?
It's
Right away?
it's immediately.
Okay.
Now, if they graduate off of hospice, they revert back to what they had unless they do some more paperwork to get
Okay.
that done, so. Did you have a question?
I was just gonna, give you a little praise from Heart of Hospice. I had an opportunity to sit with someone recently, and it was late in the evening, and, I knew that, she probably just had hours, but when I walked in, I felt like she was very uncomfortable. And, family just wasn't really sure what was going on, but anyway, to make it short, I called, the hospice nurse, got her real quickly, explained what was going on. She called the physician and got an order for me and said to me, if this is not better in an hour, you call me back. And that was great. And about 50 minutes later, she called me, and I was so impressed that I know she had other people she was taking care of, and it was late at night, but it was impressive that
Yes.
she was still thinking about whether we were making progress and feeling better, or
Yes.
ease the discomfort, and it was really a good ending
Yes.
for this lady that I was sitting with, and it was just an accident that I happened to be there at the right time, I guess.
Thank you for sharing. That does make us, I know it makes us feel good when we know they're going the extra mile to make sure things are the way they should be. And really, it comes down to that reassurance too. Like when we had our family, like me and my husband both are in the medical field, and we're like, oh, we're not doing enough. Like we kept calling, and just that reassurance it was different when it's your family and your friends, and that's what we
Especially if you're in the medical field.
Yeah.
Well, I was gonna say, there I was as a nurse, and the daughter was a nurse, and the patient was a nurse, so,
Stressful.
Hospice nurses are tough.
Yeah.
It's a tough bunch, yeah, they
Yes.
get into a lot of difficult situations, and they're out there kind of by themselves, out in the world, and, a lot of people have different expectations of what death is gonna look like, and whether they don't want us to do something that seems like it's hastening
Right.
death when we're trying to make someone comfortable,
Exactly.
which the act of making it comfortable may actually hasten death in a sense, because if you're fighting, you're uncomfortable, but you're breathing. But if you finally relax and get comfortable with whatever we do, you may stop breathing. And we kind of have to work through that with families and make sure they don't feel guilty because they're giving mama morphine or something and things like that. So.
Well, it was just confirmation that what we were talking about, what I had shared with them, was what was said on the phone. So we were able just to walk on through that.
And not to mention too, just these patients and families, everyone are grieving before they probably even signed up with hospice, to be real. And it's such a sensitive time for them, and it is, our goal is to meet them where they are. So like if they're not hospice minded, we have to approach them very kindly and sometimes have very blunt conversations, because a lot of these people are not getting conversations from their, providers that are involved in their care. for whatever reason. It's an uncomfortable conversation, and we're just taught to save, and we gotta look at the quality, and that can make families mad at us, and when we're just trying to, we don't want them to lose hope, but we also don't want them to have false hope and not get those small goals that they really truly want. Like maybe they just really wanted to be home and see their grandkids, but they've been given false hope. Let's go to this MRI, and if they never make, it's just a slippery slope sometimes. So, like you said, the hospice nurses, they got a full time. Yes.
I have a question. The nursing homes, they have a contract with a specific a program, or they can choose anyone they want?
It is a joint affair. So the facility gets to choose who they would like to have in their building, and the hospice gets to also choose if they want to have that contract. So we have contracts that are called evergreen, and every year they renew automatically. But there are some facilities in our area that is going towards having their own comfort program and not providing the hospice benefit at all. So there are a couple that do not have hospice contracts.
Okay. Yes, I have experience with that. There's to have somebody in a nursing home, and as soon as I knew an emergency was there, so that they called me, emergency here, you need to be here, and it was for what? For hospice. Oh, wait, I'll be there.
And a lot of times it is, some facilities have preferences who they have in the building more often, or if that person was at the hospital and the plan was to discharge, we talked about palliative provider goes in there and talks to them with a hospice liaison, and it's kind of a seamless transition. But just like everything else, there is patient choice. I think we just get caught up in our routine, and sometimes it just goes faster than anybody can move. But
they did a pretty good job. Just was like, I just didn't expect it when they called me. Whenever you have them here, you need to come in. But okay, I'll be my way. But that's the reason I was assuming they have a contract with a specific hospice.
And you can be in a nursing home and have hospice.
yes,
And not necessarily the nursing home doesn't necessarily have a contract
They
with
do.
hospice.
we do have to have contracts with them to provide care. Yeah.
Okay.
So I think the only facility who isn't doing contracts right now is Valley Springs in Van Buren. But all the other ones have contracts, and I'm pretty sure that all three of us, Mercy, us, and Area Agency, pretty much have contracts with them all.
So I'm gonna talk about something a little different with, just personal experience, but, when you talk about hospice and you're trying to tell people about the different things, like they have the pastor and the social worker and all of that stuff, so, and hopefully I don't cry when I say this, but, so, my mom was on hospice. When my mom was on hospice, and she didn't talk anymore, and the pastor came and he sang with her. She didn't ever speak again, but she sang. That was pretty cool. Yeah, that was pretty cool.
So, John Hamby?
Yeah.
Yeah.
Yeah, it was.
Big singer.
Yeah, and it was so cool because, I'm sorry, I get emotional about it,
No,
but
that's good.
it was really cool that he did that.
Yeah,
And
no,
just came and sang her
he's
favorite
great, yeah.
Christian song with her, and it was kind of cool.
Yeah, I think we talked about that in our meeting, we meet once a week and have, discussion of patients, and he talked about it, how he was impressed that she sang with him.
Yeah, but she never spoke.
Right.
She never spoke from the time she came from the hospital.
Yeah, I thought that was neat.
You start singing to her, Candace?
Girl, I can't sing.
Some people really not that thing.
Yeah, she was told me to shut up.
I think I took up the majority majority of the time, so I'll let Holly, do you want me to, okay, now this part, we usually have you guys come up, introduce yourselves, and just share something that's going on at your place. We just got about 15 minutes before 1 o'clock, so we'll do our little fast elevator speech. Whoever wants to go next?
Well, I think I pretty much know everyone here, but I'm Ashley with Mercy Rehab. We're just another option for inpatient rehab. Piggyback off the hospice thing, just so that way y'all are educated. I think she mentioned it. So if they're wanting inpatient rehab, they're wanting to change their route and they want to seek treatment for inpatient rehab, we do have to seek either Mercy or Hearts of Hospice. We have to receive a letter saying that they're discharged from their services. Then they can come into inpatient rehab. So that is an option. So if you're seeing clients and they're on hospice or palliative and they want that, they do have to come off of those services. Now keep in mind, for example, I had a patient that had a hospital bed that had all these comfort measure equipment and extra care, and I had to pull that. I would have had to have actually talked him into staying with hospice, because that would have pulled all that additional help out of their home while they came to rehab. So sometimes that's not the best choice, and we're willing to, of course, talk to the family and discuss and see if that's the right option for inpatient rehab. And anything new is just that we're staying, we have our 50 beds and we're staying higher and we're staying fuller, but we, of course, always have wiggle room. So call us if you need inpatient rehab. Remember, no referral. So give my cell phone number to anyone and everyone, and we'd love to help them. My phone number is 479-957-1700.
Oh my gosh, I knew you were gonna do that tonight.
Yeah. Looks like he doesn't.
So, I knew you were gonna do that too, Britt. I'm not a Phillips speaker. Oh, so sorry. So, I'm Cheryl, I'm the palliative care coordinator from Mercy Palliative. I work with Dr. Gabori very closely, and Michelle Holland and JC Hamilton, our nurse practitioner. JC's in the hospital making rounds for palliative care. Generally, palliative care takes care of patients that are still seeking treatments, don't qualify for hospice yet, and we see them in the clinic. We also meet the patient where they're at. Michelle goes out twice a day to homes, and we do visit patients in the nursing homes also, those that can't travel to our clinic, those patients that are bedbound or things like that. So that's a very important kind of piece of palliative care that we've started back up. Some of y'all know Catherine Mercer, who transferred out of our clinic and is in Van Buren today, or these days, and she started the nursing home visitation several years ago. And so we've started that up again, so we're very happy. We work on referrals only. We have a lot of patients, families that call us and go, can my family get on palliative care? If you'll be more than happy to call your PCP or your oncologist or whoever is your primary care, then we'll be able to take, go through the criteria and make sure you take care of it. I have some business cards if you want them, and some flyers.
Okay, thanks for coming.
I'm Candace Cox with Home Helpers Home Care. I know all of you here, I think. And we do in-home care, which is toileting, transferring, bathing, fixing prepared meals, housekeeping, laundry, linen changes. We do activities for the mind and body. We also do respite care, which is a different type of respite care than what hospice provides. We are located in 8 states now, so we are getting bigger and bigger. I think we have over 50 locations. Anyway, I'm always available to help. However, I do cover Arkansas and Oklahoma. My phone number is 479-316-4639. So, no holler if you need anything.
What place for you?
Hi.
Hi,
I'm Cassie
How do you
Barnes.
get paid?
What?
How do you get paid?
How do we get paid?
Yeah.
So, our payer sources is private pay, long-term care insurance, VA, and Medicaid. We are currently partnering with another organization that will help through dementia-type grants and funding to provide respite care as well.
Okay,
Sorry.
Hi, I'm Cassie Barnes. I'm from the Blossoms of Van Buren. This is Crystal from Fort Smith.
We are a long-term care and skilled facility. We take mostly any insurance. Van Buren takes VA contracts. We have male and female units beds available, and we do respite care and hospice. So if you need me, call me at 479-670-0073. Thank you.
Hey, I'm Leanne Battles with Access Home Health, and we had skilled services, physical therapy, occupational therapy, nursing and speech. And we actually, for the home for the holidays, we've actually increased our staff so that we can get the families home and take care of them on the weekends. So we've got openings for Saturdays and next Saturday so that they can spend the time with their families. You need me? Call me at 479-353-2758. You just never know where you're gonna see a pretzel or a taco right now.
We have costumes, yes we do. Good afternoon, I'm Teresa for Van Buren Legacy, and we have Memory Lane Assisted Living. It's independent living, come and go as you please, and we spoil you. We cook 3 meals a day, do housekeeping and laundry, and our memory care is 24-hour nurse care, CNA care. So give us a call. My number is 479-262-6466. Thank you.
I'll introduce myself if I don't have to stand up. I'm new to the group, but my company is not. So Encompass Health, my name is Jay Hudnall. I'm the Director of Therapy Operations. So like Mercy Rehab, we do inpatient rehab, PTOT, and speech. What all do we have going on new? More than I can probably pretty much keep up with. So like probably most of you, my calendar is nuts.
You have a new administrator.
Absolutely nuts, yeah. We do have a new administrator where my prior boss, Dawn Watts, has gone to a facility over in Tulsa. She's doing wonderful. I've spoken to her recently. But our new CEO is Harlow McCall. He lives in the Alma Van Buren area, kind of between, and he's been a CEO for a good while with us. You know, we're 170 hospital, East Coast, West Coast. A lot of things we've got going on is gearing up for a survey in 2026, so we'll be prepping for that. And you know, Jessica Taylor's also involved, so is our Director of Case Management. But anyway, I'm excited to be part of the group, joining, learning. I appreciate your presentation, because as a therapist, as an OT myself, I've always had questions about hospice and actively dying, or not necessarily going to be actively dying, and just some different things that aren't exactly, you know, so.
And often it's the therapist identifying hospice eligibility
Right.
from our standpoint. It's
Right.
So we appreciate it.
And then I will say what I really do like about Fort Smith. I'm originally a Mississippi boy. Came here working for Encompass on the home health side before they spun that off and it became Inhabit. But I come back out here, out this way to Fort Smith for the DTO role. But you guys are very symbiotic. Y'all really work together well.
We
from what
love
I can
each
see.
other.
You know,
We're just a big family.
so anyway, I appreciate that and I like that. I think everybody's out to do the best thing probably for the patient. So that's what we all want to strive for. Thank you.
Welcome aboard too.
Thank you.
Hi, I'm Crystal Lujan. I think I know almost everybody here. I'm with Baptist Senior Care. We don't have anything new going on with senior care. I can't speak for the other services at the hospital because I don't really worry about them. We are.
Are you separate from Baptist?
We are not separate. We
You are
are part of the hospital.
Under Baptist?
Under Baptist umbrella. Well, we just do our own thing. So that's what we do. We do have 23 beds, inpatient psychiatric care. Our length of stay is typically 7 to 14 days. We take just about every insurance. I'm sure I know that there's some contract negotiations right now with, like everybody, with Humana and Aetna and all that stuff, but we should know by the first of the year what that's gonna look like. Yeah, I also enjoyed your presentation very well as a person who's had to personally reach out recently, but we try to work with all the other providers and facilities to get our patients in and out and back to where they need to be. So any questions, just give us a call, 494-5, no, that's not right, 441-4718.
Give us your personal.
Yeah.